So welcome to tonight's forum, STI and HIV Care Update, Ask Us Anything. We are joined tonight by speakers Dr. Bradley Forsman and Dr. Sarman Balasubramanian. Our GP facilitator is Dr. Miranda Shirley. My name is Jasmine and I am your RACGP representative for this evening. Before we get started, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would like to also acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our panel for this evening. After completing her medical degree, Miranda made an early choice to take up a career in sexual health medicine. She completed training with the Royal Australian College of General Practitioners and the Royal Australasian College of Physicians Australasian Chapter of Sexual Health Medicine. Bradley is a public health physician working as a staff specialist at Blue Mountain Sexual Health Clinic and is a community HIV S100 prescriber at Fountain Street General Practice in Alexandria. He has over 20 years experience working in sexual health and HIV. Sama is a sexual health physician working at Clinic 16 at Royal North Shore Hospital. He also practices privately in the field of sexual dysfunction with a special interest in people living with HIV. He is the chair of the training committee of sexual health physicians with the Royal Australian College of Physicians and worked as a GP caring for refugees and vulnerable populations in rural areas before entering his current role. And I will now pass to Miranda to go through the learning outcomes.
Hi everyone. Tonight we're going to start with two presentations followed by a case study, and then we're going to move through to a question and answer session. Hopefully by the end you'll be able to understand the current Australian guidelines around STI testing, diagnosis and prevention, how to apply that in a GP setting, have more confidence in doing so, and an appreciation of the wide range of tools that are available to help with STI and HIV care, particularly in New South Wales. And having gone through all of that, I'd like to hand you over to our first presenter, Dr. Forsman.
Great, thanks so much, Miranda and Jasmine. So what I'm going to do is do a very brief and sort of whirlwind overview of the epidemiology of both HIV and the other common STIs that we see in New South Wales, and just a bit of a guideline update. So first off, syphilis. We're seeing an increase in syphilis infections over the years. You can see from this graph, particularly between 2015 and 2019, it's shot up. Sort of has stayed stable around that time, but there's been an increase in the number of congenital syphilis cases, which is quite significant because the outcomes of congenital syphilis are severe, as you probably already know, with birth defects and developmental delay, and etc. You can see from the next slide that the number of the people who are getting syphilis are, Miranda, could you next slide, are mainly male, but the notification rate of the male notifications has stayed roughly the same over the past 5 years, whereas with females it's slowly climbing, which is quite concerning because the more females that have syphilis, the more likely babies are to get congenital syphilis. Because of this, it's really important for us to think about syphilis in pregnant people. Syphilis really readily crosses the placenta, and a pregnant person who has been infected with syphilis can transmit to the fetus. It's associated with an increased rate of pregnancy loss and neonatal complications, as I mentioned before. But if we detect syphilis early in pregnancy and we give treatment early, then it can prevent those serious consequences for both the pregnant person and their baby. It's recommended that all pregnant people should have syphilis screening at the first antenatal visit, again at about 26 to 28 weeks, and then at either 36 weeks or birth, whichever one comes first. But if people have other risk factors for syphilis, then additional screening might be required as well. And really the only way of identifying those risk factors is by asking people. And we'll talk about that later in the forum, how to go about doing that. It's really important if you come across a patient, a pregnant person who hasn't really received much antenatal care at all, or they're at risk of not, lost a follow-up or missing appointments, they should just be screened whenever you see them, just so that we can get those cases of syphilis and treat them straight away. That's a really good take-home message from tonight, I think. Chlamydia. Chlamydia actually seems to be decreasing compared to in 2024 anyway, compared to 2023. It's about half and half, a bit more in men than women. There has also been an increase in testing as well. So this is a real decrease in a notification rate, which is good news. It's difficult to explain because, as you can see in the next slide, gonorrhea is increasing. So in New South Wales, the number of notifications of gonorrhea has almost doubled between 2022 and 2024. We had over 14,000 notifications last year. It was the highest number we've ever received in 1 year. There's been an increase in cases across most of the LHDs in New South Wales, but the largest increase, proportional increase, has been sort of out west, far west, in northern Sydney, and also out west in western Sydney as well. And that could be due to changing sexual behaviours, but also people taking better precautions or having better health literacy in the sort of the inner city areas as well. The majority of people who are getting gonorrhea are men, so usually men who have sex with men are those people, but there is an increase in women as well, as you can see there. But there has been a significant increase in men too. The concern about gonorrhea is that there is an increasing risk of antibiotic resistance to gonorrhea. So there are quite a few imported cases from Asia, Eastern Europe, South America, where we found that the gonorrhea is resistant to either azithromycin or ceftriaxone. You can see from this graph, the numbers are small, but they're there, and the risk is these might get transmitted to other people and sort of take hold in Australia. Once we don't have ceftriaxone and azithromycin, it's going to be much more difficult to treat. So it's really important that we keep an eye on this and we test and treat people as soon as we can to prevent, to try to reduce that load in the population of the gonorrhea. You've probably heard of monkeypox, or well, the virus formerly known as monkeypox, or Mpox now. So just quickly, Mpox is related to smallpox. It's reasonably common in Western Africa, West Africa, but there's been quite a large worldwide outbreak of a particular type since 2022. We've had sort of up and down sort of cases since 2022, but you can see this year there were quite a few in January and then again some in August. It was initially mainly men who have sex with men who were getting monkeypox, so Mpox. Now, though, more recently, there have been a number of cases in women and female sex workers and their clients. So it does seem to be sort of leaching out into the broader community. So something really important to keep an eye on and be aware of. And if you're worried at all that a patient might have Mpox, which causes little poxy sort of rash and fever, then calling your local ID or sexual health physicians would be the best thing to do to work out what sort of testing and what management to undertake for that. HIV, one of the big success stories in public health and sexual health over the past few years. The numbers have dropped considerably of new infections. However, they seem to stabilize and actually gone up a little bit in the last couple of years. With HIV, it was very dominantly in men who have sex with men, but more recently, the people who we're seeing with newly diagnosed HIV are not in that group, mainly because of the use of PrEP. So we're seeing heterosexual men and women, also non-gay identifying men who have sex with men who have less attachment to the community and less health literacy around HIV and protective measures like PrEP. So again, really important to have an awareness of HIV and test a broader range of people than just men who let you know that they're having sex with men, and to talk about this with your patients and test more and more people so we can get those undiagnosed cases. I mentioned PrEP, is HIV PrEP, so that's a tablet you can take once a day if you're at moderate to high risk of HIV, and that has a very high effectiveness in preventing HIV transmission to people. You can see since it was available in 2018, the numbers of people on PrEP have gone up considerably. So there's been almost 100,000 people who've ever been on PrEP, and just in the last 12 months, there's just under 50,000 people as well. So that's really good. From your point of view as general practitioners, you can prescribe PrEP. It's just a restricted benefit on the PBS. You don't need any special requirements apart from doing HIV and STI screening and checking people's renal function. But if you need any assistance with that, you can look on the ASHM website. There's a good sort of module there, but also speaking to your local sexual health clinic to get advice on how to do that for your patients. In New South Wales, you can see those numbers are the same. So there's been an increase in the number of people going on PrEP, which is great. And that's why our HIV numbers are dropping. So who should be offered opportunistic STI and bloodborne virus screening? There's a list here. Then this comes from the HIV and STI strategies. But really, if anyone asks for it, I think that's the most important thing. If someone comes in and asks for an STI screen, then you should do one. And Sama's going to talk in a sec about sexual history taking and how to get information that you need to do the right tests. But it's really important, I think, if someone wants an STI test, they probably feel that they are at risk, and they probably are at risk. And it's best just to do the test, just to make sure. It's best to do a test and it's negative rather than not do a test and miss a case of HIV or syphilis. But in particular, these are the people who are at higher risk of STI. So Aboriginal and Torres Strait Islander people, First Nations people, of course, men who have sex with men, we all know probably. Sex workers are also at greater risk of HIV. People and STIs, people who inject drugs, people in prisons, and of course, people from high prevalence countries are going to have a higher risk as well. And we also find that FIFO workers and travellers also tend to be at greater risk, and also anyone who has got who's previously had an STI or has got a current STI are probably more likely to have another one or have HIV. So it's important to do a comprehensive STI screen, not just do tests for one infection. Young people are also at greater risk as well. But basically, if anyone asks for an STI test, do one. And I think that's it for me. So I'm going to hand you over to Sama.
Thank you, Brad, for that excellent rundown around the epidemiology. And particularly, I think that slide on syphilis testing, I think is really important because not everyone knows that it's recommended to do more than one syphilis test in pregnancy. So we're going to talk a little bit about sexual history taking. Many of you do this already. This is more of a key principles and suggested approach, and perhaps a way to navigate some of those conversations with patients. And we all have different patient groups and populations that we have varying levels of comfort with, often due to our own experiences and attitudes and values about sex. So hopefully you're able to take perhaps some phrases and expressions away that will assist you in having these really important conversations. So we start off with a question. Like any presentation like this, when we ask a question, it's loaded. So when would you start a conversation about sexual health testing? You've got three options: first visit, follow-up appointment, or when requested. Interested in seeing what everyone comes up with.
We've got lots of answers coming through now. I'll just give it a few more seconds. If anyone wants to pop their answer in, that'd be greatly appreciated. Let's put that on there.
Yeah, cool. I mean, it's all of the above, isn't it? You can offer it at the first visit, you can do a follow-up when requested. And if we paraphrase when requested with when requested by the patient or the clinician, such as yourself, that would be, I think, the correct answer. And as Brad has mentioned, if someone asks for an STI test, it's best to test first and then ask questions. As opposed to interrogate first. I find that often starting the testing can break the ice, particularly with people that are really hesitant and cautious around their sexual history taking. So when we start the conversation, we talk about raising it opportunistically. So whenever you can, and whenever is appropriate as well, because people need to know in advance that you're going to be asking them these questions. A hook is a really interesting concept. So could it be a part of something else? If we're asking about periods, we might say, as part of asking people about periods, we ask them questions about sex and partners. I shy away from using the word sexual history. I think it means different things to different people. I tend to just say ask about sex and partners, and that tends to get the message across to people and makes it sound certainly less daunting and less formal. Sometimes a patient may request and check up for STIs as well, in which case we've got to ask them these questions because that's our responsibility as clinicians. So we might integrate sexual history taking into SNAP. Again, as a GP by background, I mean, we have SNAP really ingrained into us as a mantra almost. But there is an extra S that I've always added in as sex and sexuality and sexual partners. And when we ask those lifestyle questions, we might signpost and flag that in advance. I ask everyone questions about smoking and alcohol, about diet and exercise, and about sex and partners. Is that okay with you? And then you can kind of continue on that way. And integrating it perhaps into one of your templates, as many of us use templates these days, might be a helpful reminder as a clinician that it's something important to discuss with your patients. So we normalise and we signpost. I think that first bit where you get permission from the person takes precedence over the questions you ask. What's really important is we make sure that the person in front of us is ready for us to ask them those questions. If they're not ready, then interrogating them about their sexual practices is just going to turn them away, and it's going to be a bad experience for them and for us, and we risk de-engaging people in care. And the whole purpose of good sexual health care and the principle is engagement in care. If we can get people coming back to us and be able to candidly speak about their history and about their sex and partners, then we're on the right track in terms of healing them and assessing for STIs and sexual health problems appropriately. Confidentiality is really important. Remember to mention confidentiality and its limits, particularly when we talk about things like risk of harm to a person and other people. And establishing trust, I think, is really important. We all do this with our patients in terms of building rapport, and use your spidey sense to figure out, is now an appropriate time to take a sexual history or not? We can say statements such as, the questions I ask will help me know what tests to offer you or arrange for you. We ask everyone the same questions. These questions are personal and you may not have been asked these before. Let me know if there are any questions you have about my questions. If there are any questions you don't want to answer, just say pass. And if you want to clarify anything, just let me know. And if you kind of start with an expression like that, it tends to ease up the patient and reduces their level of nerves, but more importantly, our own level of anxiety about these questions we're going to ask people. Because asking these questions can be anxiety provoking for clinicians as well as patients. STIs are common, so we might say most STIs actually don't have any symptoms. So this is why we ask people and do testing for them. And we don't want to make assumptions about sex partners. So you might choose to use very deliberate language with your patients about how we ask them. We're going to go through that in a slide or two. But we try not to make assumptions about what kind of sex people are having and who they're having sex with. And if people use a term or an expression that we're not familiar with, it's always a good idea to clarify that with them and say, can I just clarify what you mean by that? And sometimes the get out of jail free card as a clinician is to say, different people mean different things by that. Can you just explain what you mean by that term? Be cognizant. I mean, when talking to people about sex and sexual health and STIs, I mean, you are a self-selected population of clinicians that are interested in this space. But despite that, we all have our own positive, negative, and neutral attitudes and values about sex and partners. And that influences how we ask people questions, how we interpret the information they tell us, what investigations we order, how we break diagnosis or news to them about STIs. And how we follow them up and care for people with STIs, because we've all had our own experiences when it comes to sex as well. So be cognizant when you have an experience where you think, I don't think that went so well, or this is giving me the tingle on the back of my neck and my spidey senses are flaring a little bit. And that's where you utilize peer support and debrief with trusted colleagues and supervisors, because we all have supervisors and mentors and peers in our practice, regardless of our level of experience. It's important to do some debriefing to explore why I felt that way and how can I manage that better next time. So the basics are really simple. Who you're having sex with, what kind of sex you're having, and when did you last have sex with someone? You might utilize the 5 Ps of partners, practices, past STIs, prevention of STIs, prevention of pregnancy. But in terms of the who, you might ask, so do you have sex with men, women, or both? Do you have sex with people with penises, with vaginas, or with both? What kind of sex are you having? And you might leave that as an open question and then ask them more specific questions about vaginal sex and anal sex. With anal sex, people are often familiar with terms such as top, which is insertive anal sex, or bottom, which is receptive anal sex, or they might be familiar with both, or verse for versatile, which means they have both insertive and receptive anal intercourse with their partners. And in terms of oral intercourse, we might ask that both ways, in particular if both partners have a penis. When did you last have sex with someone, I think, is a really important question as well. And also, when did you last have sex with someone else? And trying to determine back at least 3 months, or thinking about when the last STI screening would have been, and marrying that against what's relevant in terms of the question we're asking and the presentation that they have. So you only take as much information as you need to be able to determine appropriate testing and treatment. So we ask about that previous screening, so past history of STIs, and then consider other risk factors. And these might be demographic things, or these might be questions that we ask people about. It's important to think of higher rates of certain STIs among population groups. So, for example, in central and rural areas, there are higher rates of infections such as trichomonas among Aboriginal and Torres Strait Islander people. Among gay and bisexual men who have sex with men, there are higher rates of HIV and bloodborne viruses. Among sex workers, again, higher rates of STIs and HIV. Brad's kind of covered this as well, but this is an opportunity for you to be able to ask these questions. And when we ask these questions about things like sex work, we may not necessarily say, do you do sex work? We might ask, have you ever been paid for sex? That's kind of a simple phrasing of the question. And instead of saying, you know, what are you using at the moment? What drugs are you using? Have you ever used drugs? And what have you used? And then also asking the corollary to that about chemsex, which is when people use drugs to enhance the experience and pleasure of sex, or it's in and around sexual activity, in particular drugs such as G or GHB and methamphetamines, injected or otherwise. We might ask questions about, do you use drugs at the time you have sex? And that may greatly increase the risk of bloodborne virus exposure for a person and the risk of HIV acquisition. And then again, that travel history. And we all know the importance of sexual histories going together with travel histories. Menstrual history is important for anyone with a uterus. I think particularly intermenstrual and postcoital bleeding, particularly because that can suggest an STI diagnosis or the possibility of pelvic inflammatory disease, and postmenopausal bleeding, for which we should all be doing appropriate investigations. But don't forget to ask older people about their sexual histories as well. When I like to ask people about sexual histories when they're not necessarily expecting it, I tend to always very deliberately use that permission. So you've got to link it in and say, for everyone who has this kind of bleeding, I ask them questions about sex and partners. Is that okay? And they often volunteer the relevant information, and you can just move on. When you do start that sexual history, though, my key tip for you is to think, make it normal in the way we phrase questions and statements to people that having sex is okay and a normal and natural part of life. So we don't ask questions like, do you have sex or do you masturbate? We ask questions about how you have sex and what kind of sex you're having. So it carries an inherent assumption that the behaviour is part of normal human expression. Contraception and gynae history, we all know that to ask that for appropriate individuals. And obstetric history is relevant, particularly if there's any chance of someone being pregnant. And as Brad has alluded to, syphilis in pregnancy is emerging as an increasing problem across the board, even in metropolitan areas of Australia as well. And so language, if we're not sure what language to use with people, we can just ask them, what can I call this? What do you want me to call this? So often I talk about people with penises. Is that an okay word for you? I talk about people with vaginas. Is that okay with you? And people may prefer a different expression for that. And in terms of the kinds of sex people are having, let them use the language that's comfortable for them and then clarify the information. And remember, everyone has a different definition of what sex actually is. And some people may consider kissing a form of sex or holding hands a form of sex. And that's relevant, particularly as people age over time. So we want to clarify whether people are actually having any genital contact at all. So we move into the case study review and discussion. So I believe now, Miranda, you're facilitating this, aren't you?
And now I'm certainly facilitating the discussion, but I wasn't sure about which one of us was going to talk through the case study. So I might ask you to talk through this one, Sama, because I know you've presented this particular case before, and we might do it between us.
Sure, not a problem. So I'll kick us off, and Miranda's my senior, so Miranda can tell me if I'm saying anything wrong. So is Brad. So we'll work our way through this as the three of us. So Joey's 25-year-old. We're going to presume he's a cisgender male living in Sydney, and he's come to you today stating he's got an ulcer and he has some discharge coming from his penis, and he's noticed it for a few days. We'll say it's 3 or 4 days. He's embarrassed about it, as most people are when they have this problem, and he's concerned he may have caught something. And he's never had STI testing before, and he's recently gone to the Gold Coast for a brief holiday. So Joey says he has male partners, so males with a penis, and he's had some recent partners with penises while he was in the Gold Coast. He has no regular partner and no other major medical issues or other risk factors, such as things like injecting drug use, for example. He mostly uses condoms, but one broke 2 weeks ago in the Gold Coast, and that was his most recent partner. And his partners are casual and anonymous, so we're going to presume that we don't have any contact details for partners, and none of them have contacted Joey informing Joey about any STI diagnoses. And when you examine Joey, because you're diligent clinicians that examine people when they have symptoms, you notice that he has a single shallow ulcer with an indurated base and a rolled edge on the shaft of his penis, and it's not painful. And you notice also a degree of myotitis and some purulent discharge. We're going to call it yellow-greenish discharge emerging from his urethra.
All right, so I think, Sama, we've brought up a couple of the really key features here for this particular person, in that we've got identified risk factors, being someone who is a man who has sex with men and with a recent condom break. And we've got two quite different symptoms that may or may not go together. We've got both an ulcer, which is a distinctive looking ulcer that's a non-painful one. And we've also got some discharge from the penis as well. So I think it's fair to say what investigations we want to do are both going to be guided by what would be the normal investigations for men who have sex with men, but also the symptoms that he's presented with. So would you like to talk us through what you think are the key things that we would need to do in the GP setting? Remember, of course, not everyone's going to be able to do all of the tests. It depends on where you're located, what your local labs can do. But where should people start?
So Miranda, I'll take this first one, as you've suggested. I really like your framing of what are the normal testing or the standard testing that we expect to do for this individual. It's a really good way of not getting overwhelmed by the symptom complex that the patient presents with. And then you'll find that the extra things we have to do might be 2 or 3 other things, but it's easier to think about and we don't have to think them through. So the standard investigations we do for men who have sex with men who present for an asymptomatic sexual health screen would be blood-borne virus testing. You do bloods for HIV and syphilis serology, and you do hepatitis A serology if they hadn't had hepatitis A immunizations before, Hep B serology to confirm Hep B immunity, and you'd want a bit about their immunity history, and hepatitis C serology as well. And you might consider renal function, an EUC, and a urine protein creatinine ratio if you're thinking or considering PrEP prescribing for an appropriate person. And then we would do bacterial STI testing, for which the standard is chlamydia and gonorrhea PCR. And we do that usually in 3 sites, a urine test, a throat swab, which may be clinician collected, and then a rectal swab, which may be clinician collected if they're symptomatic, or the patient will self-collect it as well. And so that's your standard testing. And then on top of that, you also have a couple of symptom complexes here. So you've got someone presenting with purulent urethral discharge. We're going to presume that Joey has urethritis, of which the commonest causes would be chlamydia and gonorrhea, although there are other reasons for urethritis as well. For anyone with urethritis, particularly if it's purulent, it's important to consider gonococcal urethritis, which typically presents with a more purulent discharge than other forms of urethritis. And so you'd be collecting a gonococcal culture from the site to try and culture the gonorrhea. And if you're looking for gonorrhea in one site and thinking about treatment for gonorrhea, you've also got to culture the other sites in case they have asymptomatic gonorrhea in the throat or the rectum. Because of the ulcer, there's a few ways to do this. Now, depending on what the ulcer actually looks like, I think this is leading you towards doing a syphilis PCR of the ulcer. But let's presume for a second that the ulcer, like many things in medicine, is unclear. And we have to go off the epidemiology and the location of the ulcer to determine the testing. So the PCR testing you can consider would be a syphilis PCR. You might consider a HSV or herpes simplex virus PCR if it's an appropriate ulcer. And you may also consider a monkeypox PCR. And the monkeypox PCR may be appropriate depending on the look of the ulcer, because this case was written before monkeypox came in, if I recall.
That's a great set of answers there, Sama. And I think for people who are worrying about all of these different PCRs and tests and do I know if I have all of the right swabs, in the end, you can do what you can do with the swabs that you've got, because either you're going to send those swabs away and the lab's going to be able to do the tests you ask for, or maybe they can do most of them, but 1 or 2 couldn't be done from the swab that you sent. But it's better to send what you can and worry about it later if we need to organise some extra testing. I think I might tackle question number 2, which is about why do we need to do those cultures? We've already got PCR for testing for gonorrhea. Why do we want to send for cultures as well? Well, it's partly because of Sama's point that not everything is gonorrhea. There are other things that can cause urethritis. But as we heard in the first talk tonight, we really, really need that antibiotic sensitivity and resistance data. And we can only get that reliably from the bacterial cultures. But gonorrhea is very fragile. So we want to get a sample as soon as we can, certainly before that person started antibiotics. We want to get samples from all of the spots it might be. And we want to get those sent away as quick as possible to give them the best chance of growing when they do get to the lab. So, Sama, coming around to question 3, have you got any thoughts about treatment at this point?
Well, can we throw it to Brad? Because I feel like I've been interrogated already for question 1.
You're doing it so well, Sama, doing it so well. I mean, for example, it does sound like that ulcer is due to syphilis, but it could be something else. So if you did have some penicillin available in your practice, I'd probably be saying, give treatment for syphilis, for primary syphilis, which was just those 2 injections of the Ben-Pen, or the guidelines have recently changed because there has been a difficulty in getting penicillin in Australia, so you can actually give doxycycline instead, 100 milligrams twice a day for 2 weeks for primary syphilis, which makes it easier actually to treat in general practice now, which is brilliant. So you don't have to send people to sexual health clinics to get that injection. And the other, I guess, for the urethritis, do we give treatment presumptively or do we wait? It's depends on, is the person going to come back for the treatment, or are you going to lose them to follow up? So if you think that people are not going to come back for treatment once the result comes back, then it's probably worth giving presumptive treatment for both gonorrhea and chlamydia, because they're the 2 most common causes in this guy, because they're the highest risk ones. But it sounds like he probably will come back. I mean, he sounds quite concerned. So generally, we would wait for the results to come back so we don't use antibiotics too much. And we won't get the antibiotic resistance back before the PCR comes back. So we'll still be giving the ceftriaxone and the azithromycin if it's gonorrhea. But generally, I think that's would be what I do in my general practice, and certainly in my sexual health clinic, we would look at the swab under the microscope. We would know if it's gonorrhea on the day. So we're lucky in that regard.
And Brad, I was going to ask you to tackle question 4 for us as well. Other issues that might be important to consider for this person?
Oh, so many. I mean, he has never had an STI screen before, which that rang alarm bells for me. And we didn't get a full sexual history, so how many people he's had sex with over his lifetime. He might just be recently sort of sexually active. But I think it's important, once these sort of immediate issues of treating the symptoms that he has, so we've sorted that out, then having a chat, non-judgmental and gentle chat with him about his risk of these infections, and trying to get him into a program of regular screening is the first thing. Also trying to work out what sort of risk he does have over time and whether he should be on PrEP, HIV PrEP, because if he's at risk, he's got either syphilis and gonorrhea, then he's at risk for HIV as well. So he probably should be on some form of PrEP, even though he does try to use condoms all the time, apparently, just for backup. I didn't mention before, but PrEP can be done either daily or what's called on demand, so people can take it on demand. But then there's also the other issue of HIV PEP, which is the post-exposure prophylaxis, which he could have done 2 weeks ago when the condom broke, and that would have prevented any sort of HIV. The other thing is that there are window periods for particularly the bloodborne virus infections. So HIV has a window period of about, well, say 4 weeks, but can be up to 3 months. And so a test that we do now from an exposure 2 weeks ago may not actually pick up HIV, so he would need to have another test at some point. And for the bloodborne viruses, Hep B and Hep C, it can be up to 6 months. So we want to make sure that he has regular testing for those.
And Sama, you brought up the question of the hepatitis viruses as well and immunisation. Would you like to speak to immunisations that this man could be thinking about?
Yeah, so there's a few immunisations we can think about. So as far as sexually transmitted infections we can protect people from, so hepatitis A, for which you can get 2 doses 6 months apart, Hep B, 3 doses at 0, 1 and 6 months. And remember, with hepatitis B, we can all get into a bit of a schmozzle here. As long as you're not immunosuppressed and you register a surface antibody that's above 10 and you've got documentation of that, that actually means you have immunity, and we're pretty sure that that remains lifelong. There are some exceptions to this, but if you've got a positive surface antibody for hepatitis B, we're pretty positive that's lifelong immunity, particularly in terms of sexual contact. There's monkeypox immunisation, so 2 doses, 1 month apart. They're the other thing you can think about. And you can also consider reviewing vaccination histories, because depending on when they were born in Australia or overseas, and what the individual immunisation schedules are, some people may not have received one or the full course of HPV immunisations. And we've got more data these days, and even in young people who've gone beyond the 20 years of age that Medicare funds for catch-ups or the NIP funds for catch-ups, there is some evidence that immunising against HPV in this population group, particularly for men who have sex with men, is actually beneficial in reducing the occurrence of HPV infection, and in turn actually reducing the disease burden of things like malignancy of the genitals caused by HPV infection. So that's my general approach to immunisations for this group.
Fantastic. And I think we should also point out that HPV immunisation is protective for head and neck cancers as well, an increasing number of which are HPV associated, and anal cancers also. So I think we've already really talked about this question of follow-up when we talked about the need to make sure there wasn't and missed HIV, hepatitis B or hepatitis C that hadn't had time to turn up in the testing yet. And of course, we can add to that making sure that we think our treatment has been the correct treatment and has worked. I think now might be a good time to move on to some broader questions rather than the ones just related to the case. We just got a follow-up for what happened for Joe, first of all. Sam, I'll hand back to you since you started him off. You can finish the case for us.
Thank you. All right. So Joe he's positive for syphilis on his blood test. We're going to presume he has a positive antibody test and a high RPR titer and a positive treponema pallidum PCR from the penile ulcer that you've collected so expertly. The PCR and cultures from his throat, rectum and urethra are all positive for gonorrhea, which is ceftriaxone susceptible. So Brad kind of made an excellent point about at what point do you treat for the gonorrhea? And I think regardless of what stage you treat, whether it be now, after initially treating for syphilis, or at the time of diagnosis, taking the cultures before you give him any antibiotics is the most important thing, particularly from the AMR data perspective. So I think so long as you've taken the cultures first, you've done the right care and treatment. And if he comes back 3 or 4 days later because you've got a gonorrhea result, that's fine. If you treat him on the spot at the time, we would have only given him 1 gram of azithromycin plus his ceftriaxone, although we would have expected the ceftriaxone to have knocked the gono on the head if it was ceftriaxone susceptible. But if he came back the second time around and he has throat gonorrhea, then our usual recommendation is to give 2 grams of azithromycin with the 500 milligrams of ceftriaxone in terms of treatment. So I think so long as we'd done that, we would have done the right care and treatment given the provisional result, and we've treated for syphilis.
I'd like to hand question 1 across to Brad for starters. You gave us a good overview of what's going on with the epidemiology of STIs. What do you think are the most important take-home messages for New South Wales GPs?
I think with regard to HIV, it's the broadening of the epidemiology of the people that were getting notified newly with that, and I think for GPs across the state, it's important to be more aware to test for HIV, not just for men who have sex with men, but for a broader range of people. Just have a really low index of suspicion for that. And also, I guess the other thing I'd mentioned before, it is very easy to prescribe PrEP. All GPs can prescribe PrEP. You don't need any special powers or anything like that. You can just do it. There are good guidelines on the ASHM website on how to do that, and you can also ask your local sexual health clinic for advice on how to do that as well. So I think it's really important for everyone to realise. And the STIs and syphilis is the big thing. So syphilis is increasing in men and now in women as well, and we are seeing those cases of the congenital syphilis, particularly in rural areas, but also in metropolitan Sydney and Newcastle as well. So it's really important for people to do that antenatal testing, but also increase syphilis testing in more general populations as well.
Mm-hmm. And I think with the question of PrEP, if people aren't feeling confident, those flowcharts that are available on the ASHM website are really excellent. It's got it all in a single A4 sized piece of paper. And of course, you can always ring and ask for help as well.
Yeah.
I'm going to ask you much the same question, Sama. If we roll over to question 2, you'll see that it's really just saying a similar thing again. From your perspective, what do you think are the most important guideline changes? I think we've talked about the syphilis one in particular as being a big change. Can you think of other things that you think impact day-to-day general practice?
Yeah, I think there are a few key principles, and I've kind of tiered this according to how much of this care you actually provide in your practice. So it's not a bad idea, particularly if you want some extra CPD, to click on that link on the STI guidelines website, because there's a summary of the recommendations as well as a 60-minute webinar that gives an excellent breakdown of some of the data behind why these recommendations were made, and changes and updates for STI guidelines. So first things first, it's recommended that all sexual health testing or STI testing includes a HIV and syphilis serology. That's for all people regardless of age or gender or sexual practices. That is a change from in the past, where clinicians may be familiar with some recommendations for chlamydia and gonorrhea testing for some people, but no bloodborne virus testing. So the idea is that HIV and syphilis testing is integrated into routine STI testing for everyone. The second recommendation was that doxycycline is recommended for the treatment of chlamydia infection at all sites as the primary method of treatment. You can still use azithromycin as a secondary option, but that's reserved as a secondary option if you really need it for a particular reason. But doxycycline is the first-line treatment for all sites of chlamydia infection. A couple of more advanced things in terms of hepatitis C treatment. There's no genotyping requirement for treatment because we have pan-genotypic treatments for hepatitis C treatment, and we don't exclude or preclude someone from treatment for hepatitis C based on current injecting practices. If anything, it makes hep C treatment more of a good idea. The other thing is, in terms of trans and gender diverse populations, there's a bit of change in the section on the website around guidance around what words to use for anatomy and for the kind of sex that people are having, and also a recommendation to consider PrEP and contraception depending on someone's anatomy. So kind of remember, if you get someone where they may be trans or gender diverse or presenting differently to what you may have originally expected, to consider whether that person is eligible for and requires contraception, because gender affirming hormone therapy may not necessarily be sufficient or suitable contraception, and also consider PrEP prescribing based on what kind of sex people are having. And think, if someone with a penis has sex with other people with penises, then the likelihood of HIV acquisition goes up, and we should think about having a discussion about PrEP with this person.
Thank you for that, Sama. I think those are all important suggestions, and I think this is another one of those resources that I'd really like to plug. The Australasian STI Management Guidelines are free. Anyone can log in and find them. They've got absolutely excellent advice about what screening to offer what person, about what tests you need to send for syndromes or for specific infections, and also what's the standard management. So they're a really wonderful, up-to-date resource for managing all aspects of sexual health care. If we could move on to the next question, please. I'm going to hand this over to you, Brad, because Sama, you talked a lot about taking a sexual history. Have you got any tips that you want to tell us about, Brad?
Sama was very comprehensive, and actually what he described is how I do it in my general practice as well as in the sexual health clinic. I guess it's in sexual health clinics, it's easier because people come in expecting to be asked about their sex lives. Whereas in general practice, if we're raising the issue, as Sam said, it does make it more difficult, I guess, or you have to be a bit more careful and more circumspect about the language you use, and don't be too sort of in their face about it with the language. And so just I think using the hook, normalizing it, as Sam was saying, and particularly if you're seeing someone who belongs in a demographic that you know is at higher risk, or a young person who's coming in for something else, could maybe what we've done in my practice is say, oh look, we're doing chlamydia screening in all people aged under 25 for this month as part of a QA thing. Can we talk about that? And then do this, and then do the full sexual health screen as well on top of that, if they agree, of course. But just things like that. Sometimes, I mean, we sometimes say to GPs, oh, you know, someone comes in with a sprained ankle, just offer them chlamydia screen, but that's a bit weird, I think. I think patients might go, ooh. But yeah, you just need to sort of read the room and see what the patient is going to respond to the best. You know, with the patients I know well, I can just ask them straight out, you know, what they've been up to lately, and those. But with new patients, you just have to be a bit more careful.
I'd agree with you both that I think it's all about signposting and choosing your moment. As long as people understand why you're asking the question, then they feel comfortable answering it. They don't think you're just being nosy or asking for your own reasons, whatever those might be. And I think there are a lot of opportunities in general practice. You know, if someone's coming with abdominal pain, perfect opportunity to say, well, you know, that could be coming from the bowels, that could be coming from the kidneys and the bladder, or it could be coming from the reproductive tract. Let me ask you a few questions about your periods and about your relationships to help us work out what the problem's about. And in that context, you say, I'm going to ask you questions about all three of those things. And you're going to start doing that, and it's all going to make sense to them. Or I liked what you suggested earlier, Salma, as well, where you said, to help me work out what are the right tests for you, I need to ask you some questions. That makes sense as well. So as long as you explain why you're needing to ask the questions, I think people are really open to answering them in that case. If we could move on to the next question, I'm going to keep this one with you, Salma. It's about this stigma and awkwardness in asking questions, and about techniques for building up confidence and patient comfort and that patient-centered sort of care. What are some of the tricks that you use to help your patients feel comfortable and help yourself feel comfortable asking these personal questions?
Thanks, Miranda. I mean, I think step number one is acknowledging that, I mean, we all carry stigma within us. The reason it's awkward for our patients and for clinicians alike, regardless of your level of experience, is that this does take us to a place of discomfort. And you can only really get to comfort by asking questions that give us discomfort. Unfortunately, there's a need for exposure for us as clinicians when we ask these questions. There are several resources and methods you can use. Things that I've done in the past have been, you know, wearing a pride pin, having a couple of flags in my room, just indicating to people that it's a safe place for you to ask questions, doing things such as putting pronouns after your name on your website, making a statement on the clinic website or in the clinic about it being an open and safe place for people to disclose and share their stories for their care. And then you can think about doing some CPD. So Asham has an excellent trans and gender diverse sexual health care e-learning that was developed in combination with the AIDS Council of New South Wales. That's an excellent course that covers a lot of language and appropriate terminology when it comes to care. When working with culturally and linguistically diverse communities, it's not a bad idea to look at resources on places such as the Multicultural Resource Centre and Asylum Seeker Resource Centres. They often have some fact sheets and information about having safe conversations with people in the community. And for Aboriginal and Torres Strait Islander people, there are cultural safety and cultural humility workshop modules. There's a module that the RACGP offers. I did it myself about a year ago. I thought it was excellent. And often either your organisation or other resources, you might be able to find something. But I'd start with the RACGP's own resource about cultural safety and cultural humility as a starting point to have those conversations.
Those are all good resources. And we've, I guess, also already mentioned a lot of the flowcharts that Asham has on their site. The Australasian STI management guidelines are an excellent resource as well. And there are always people you can ring, ask for advice. Moving on to the next question, it's a little bit more of a specific one, and I'd like to direct this one, I guess, initially to Salma, but also, Brad, please feel free to jump in with this as well. This one's, I guess we could look at this either as being question about syphilis or a question about pregnant people, because to me those are quite separate issues that are both really important, that are potentially going to influence our decisions in terms of management guidelines and referral. Simon, what are your thoughts about this one?
Well, I might start on some of the key principles, and then I might leave it to Brad to perhaps expand on that. So key principle number one is you may have more than one patient in this scenario. So you have the pregnant person and then the partner or partners, depending on their sexual history and route of acquisition for syphilis. Number two, you need to clarify if syphilis is the only issue. Do they actually have syphilis? And what stage of syphilis we're at? And if so, what treatment do they require? The treatment will depend on what stage of syphilis, as well as where they are in their pregnancy, because the higher the RPR and the earlier the acquisition of syphilis, particularly if it happens after about 18 weeks in pregnancy, the higher the risk of placental transmission to the fetus. So it is important to act quickly in terms of syphilis in pregnancy. You need to consider comprehensive STI screening, so don't presume syphilis is the only infection here. Sometimes people may have chlamydia or gonorrhea, or may have co-infection with something such as HIV, and try not to make assumptions that the clinicians before you have done antenatal screening appropriately for this person, or that the person has undergone appropriate antenatal screening as they're supposed to. And then in terms of guideline adherence and referral pathways, I encourage anyone who has a pregnant person with syphilis to pick up the phone and talk to their local sexual health physician or ONG with expertise in this space, because it can get really confusing and complicated to have this conversation. So Brad, maybe you might want to expand a bit more on that, particularly around some of the specifics and other issues.
Yeah, I mean, as you were talking, I was thinking, I mean, one of the really important things in all of that is building and maintaining really good rapport with the pregnant person and their partner if they're around. We've had cases, I work at either Penrith and Blue Mountains, where that rapport has been difficult to engage, and people are lost to follow up, and they don't get their syphilis treatment, and the baby can get congenital syphilis. So it is really important to get that rapport going from the very beginning, and sort of be non-judgmental, be really welcoming to the people, and explain everything, why you're doing the tests. A lot of pregnant people don't like having lots of tests, and are afraid that the penicillin we're going to give them is going to harm the baby. So a lot of explanation and being nice to the patients is really, really important, and that will help throughout the whole pregnancy, and also doing the tests on the baby after the baby's born to make sure that they didn't get congenital syphilis. It is really, really important to remember that you're not doing this alone. There's always someone, and in fact, we strongly encourage to call for help. And the local sexual health clinic, ID physician, or ONG, as some were saying, would be the ports of call for that as soon as you get even a sniff of a syphilis in a pregnant person, because as some were saying, things have to be put into train really, really quickly. And I mean, to be able to adhere to guidelines, you need to know what the guidelines are. And so I'd strongly recommend you look up the updated syphilis and pregnancy guidelines that are available through the actual website as well.
And I think I'd add to that when we're thinking about the partners, we're thinking about the person not catching syphilis back again and giving it back to the other person who gives it back to the other person. They've got to remember that these are infections you can reacquire. So we do, wherever possible, have to treat contacts as well. And of course, the baby's a person who's part of these diagnostic decisions as well. We do have another question that I think we might skip over because we're running very close on time. And I'd just like to ask everyone to put forth what they think is their favourite or most useful resource that's available for people working in the general practice setting. I've already been enthusiastic about a couple of them on the way. Sama, what do you think is a particularly helpful thing?
I think contextualising the fact that HIV and syphilis testing is recommended for all STI screens, I think the STIPU STI decision-making tool from a couple of years ago is actually a really useful resource in determining what STI testing to do for an individual, but just make sure when you look at a resource like that, you add on HIV and syphilis testing to everyone, is kind of my recommendation.
Great advice. Brad, have you got a favourite?
Yeah, I mean, I agree with you, Miranda. The STI management guidelines on the web is a go-to for even me all the time as well. I look at it all the time, and I tell my GPs, my practice, to where to find all the updated information. So I think it's so useful, gets updated regularly, and yeah, that would be my go-to.
Yes, it really is a great resource.